Welcome everybody to this first webinar in 2022. So it's my pleasure to be your host for tonight. Well, I hope you're all comfortable, you're relaxed, and I certainly hope that all of you have a good internet connection at this moment. Because if you would experience some internet problems, just log out and then you can log in again through the link you received through email. But okay, fingers crossed. Well, what are we going to do tonight? Well, we're going to talk a little bit about the hip. That's on the program. And the question I'm always confronted with when I teach courses all over the world, colleagues are asking me, oh, my patient has pain in the groin or he has gluteal pain. What is the best treatment? And then my reaction is, I don't know what the best treatment is, but let's start with the beginning. What is the problem? So how do you come to a conclusion? How do you come to a diagnosis? And how are you going to set your treatment? And of course, in the musculoskeletal world, you're certainly aware of that. There are dozens of methods, dozens of approaches. And if you ask me, okay, what is the best approach? Then my honest answer is, I really don't know. Whatever approach you are using, and you feel comfortable with it, and you have success in your clinical practice, well, that's perfectly fine. So tonight, I'm not going to talk about the holy truth. Actually, tonight, I'm just going to give you, let's say, some kind of proposition of a system which could be pretty practical, pretty useful to reach more or less a valid diagnosis. But keep in mind, I'm not talking about the holy truth. Yeah, okay, that's clear. For those of you who already know me, then you know that during the live webinars and online courses, I don't show you any scientific references whatsoever. And I do that on purpose. We just have limited time together and your time is valuable. So I really would like that you have value for your time tonight. Or when you're watching this webinar in a replay version, that in 1 hour you're going to get a lot of inspiration. Of course, I talk a lot about science during our live courses on site, but this is of course another situation. Okay, well, I am, where is my presentation? Yeah, first time this year, I lost my presentation. Yes, voila, here is my presentation. Well, as usual, I am broadcasting live from our International Training Center over here in Belgium. And of course, I'm very interested to know where you are at this moment, and just let it know in the chat. I already see we have Yaya from India, we have Nuri from the UK, Oluna from Kosovo, Mohammed from Oman, Paolo from Italy, Virendra. I know you, but I don't know in which country you live. Well, we have Irene, I suspect from Bulgaria. I'm not 100% sure. So welcome everybody. Well, I have one question. Alexander from Serbia, also welcome. Join the club. My first question to start is, okay, when you're confronted with a hip patient, what is your major challenge? Yeah, what is your major problem? You can perhaps also let it know in the chat. In the meantime, I see we also have guests from the Emirates, and Virendra is from the UK. Indeed, welcome. Christo from Bulgaria. Welcome. We see each other in a few months, live in Sofia. I already look forward to it. So, write down for yourself. Be honest with yourself. Write down on a paper, what is your strength? what is your weakness? Not just with the hip patients, but with musculoskeletal patients in general. Yeah, what is your strong point? What is your weak point? Where do you want to get better? Just not only visualize it in your brain, but write it down on a paper so that you really make it realistic. And for each one of us, that's going to be different, of course. But then you know where you can work towards the future. Say, aha, perhaps I can optimize this, or I can optimize something else. And in the meantime, Trevor from the UK joined, Marian from Croatia, Hassan from Canada. Yeah, when you're in Canada right now, then I'm going to say good afternoon. For some people, it's good night, and for some people, it's very late in the night. Okay, I'm not only going to talk about the hip today, but I'm also going to tell you for the very first time I do this during a live webinar, I'm going to share a personal story with you, a very personal story, but wait and see. And I would suggest that if you have the time, that you stick until the end of this webinar, because then I'm going to give you a link, and through this link, you can download in PDF all the slides from my webinar presentation. You're going to have the opportunity to view the film of the hip examination, and you can also download as a PDF the assessment form of the hip. So a nice, valuable present, I presume. Okay. When you signed in for the webinar, you got the opportunity to ask a question, and many of you did that. And the question I asked was, okay, what do you think is the major reason for groin pain? And I got many answers. And you know what the good news is? That many of you had very inspiring answers, or a lot of different answers. Because tonight we talk about 5 reasons, but of course in reality there are a little bit more than 5 reasons. But okay, I would like to stick to 5 reasons. But thank you for your answers, because it was pretty inspiring. And in the meantime, Beverly from Guyana is joining. So thank you very much for being with us. Yeah, I'm alone here. So once in a while, with one eye, I have a look at the chat. If you have questions in between, just put them in the chat. And if I can help you, with pleasure. Okay. So we need to reach some kind of diagnosis. So we're going to examine the patient. And as I said before, whatever approach, whatever method you are comfortable with and you are successful with, okay, that's perfectly fine. And tonight, I'm just going to share with you a real nice basic examination, because there's something strange when I travel all over the world. I see that many colleagues are very, let's say, specialized in complex things and complex biomechanical theories and so on and so on. But then I notice that at the same time, many people forgot about the basics. And that's my topic for tonight. What about the basics? Okay, which tests are we going to do? Well, the purpose is to get as much information as possible with as less tests as possible. We're going to do some passive tests. We're going to do some resisted tests. And the question we always ask ourselves, what am I doing? Am I doing what I think I'm doing? Yeah, I did a piriformis test. Yeah. Do you test the piriformis? Yes. But probably at the same time, you also test a number of other structures. So in other words, how reliable is your test? And as you probably know, because I mostly tell that during the webinars, whatever examination protocol you do, if you have one positive test, that doesn't mean anything. That doesn't have any value whatsoever. We always look for the clusters of positive tests, for the clusters of negative tests. So what am I testing? So when you do a passive test, well, you ask yourself the question, what happens with the pain? More pain, less pain, the same? Where is the pain produced? Yeah. What happens with the range of motion? Normal, too much, not enough? What happens with the end feel? Okay, normal, abnormal. And when you do a resisted test, then you ask yourself, okay, what happens with the pain again, but also what happens with the force? Is there any weakness? Yes or no? So keep that in mind. So before we test, before we do the first test movement, I always ask to my patient, when you lie here on my table, what do you feel now? Are there any symptoms at rest? And the patient says, yeah, it hurts. Where? In my groin. Okay. Then we do a test, for instance, flexion. And then you don't ask to the patient, does that hurt? You always ask to the patient, does that change anything? The patient then can say, okay, it hurts more, it hurts less, or there is no change. So you go to the end of the movement, you slightly provoke so that you can test the end feel. And in normal situations, the end feel is about elastic. Okay, then we go to the rotations, medial rotation and lateral rotation. You go to the end of the movement and you slightly provoke. Normally you have an elastic end feel. When you do that too intensively, then this test also becomes a sacroiliac pain provocation test, and that's something I don't want at this moment. We can do a passive abduction, and let's imagine your patient says it hurts. And then you ask, where? And then he says, yeah, at the lateral aspect, the outside. That could go together with a gluteal or a bursitis trochanterica, because a bursitis in this area is pretty frequent. Yeah, and there are a number of bursae in this area, we could quite often discover that in our functional examination. Because this is just what I show you now. This is just a first idea. Okay. We do the passive adduction, so make sure you create space for the patient's leg. So I'm going to lift up the other leg. And let's imagine this patient has lateral pain and this patient does a lot of sport or is not used to doing sport, and then suddenly they start to do fitness and running and all that kind of stuff. And then they get pain at the lateral aspect. Perhaps there is a problem with the iliotibial tract. But as I said before, one positive test, that doesn't mean anything. So we're going to look at the package, and I'm going to give you some examples a little bit later on. Okay, we do some resisted test, resisted hip flexion, and we talk about a maximal isometrical contraction. And we do that from this position. And why do we do that from this position? Because when you do it from 90 degrees hip flexion, you stress more the psoas and a little bit less the rectus femoris. So it is mainly, in this configuration, mainly a psoas test. Okay. Resisted extension, also maximal isometrical. It's not often that this test is positive. Could also be positive in the case of a gluteal bursitis. Because what happens a lot, and this is a general remark, not only in the hip, but also, for instance, in the shoulder, that some resisted test could be positive, although there is no muscular problem, there is no tendinous problem. They are just positive because of the contraction. There is compression on some kind of inert structure, more specifically some bursa. And certainly in the shoulder, we see that really very often, okay? My advice is always don't jump to conclusions too fast. Perform the basic examination and then see what is happening, okay? And in the meantime, I have a look at the chat again. Some other guests joined, Sunday from Canada, Amar from India. Yeah, it's super that we have guests again from all over the world tonight. Fantastic. Resisted abduction. Maximal isometrical. Theoretically, you're testing a gluteus medius lesion or structure. But a lesion of the gluteus medius, a real lesion, this is very, very, very rare. So mostly when there is pain at that moment, your first idea is going to be, again, compression of an inert structure. So compression on one of the bursae in the neighborhood. But it could also be positive when there is a fracture. And Dr. Afshin from Pakistan also joined, so super that you are here. Welcome. And then we go to the resisted adduction, and of course this is the major test for our adductors. Of course, a well-known famous sports lesion. But not only there could be an adductor problem, there could also be a pubis problem. And more about that also a little bit later on. And then we perform the passive extension. An important detail, and allow me to make a little drawing now. Important detail is that you give, let me change the color, that's going to be better, that you give counter pressure over here, that you don't put your hand over there and then do extension, because if we would be doing this, then this is not just a hip test, but you also have sacroiliac and lumbar involvement, so it's a better idea that you direct your pressure in this direction so that it's more a hip test. And also, little detail, make sure the knee of the patient is extended, okay? Voila, I'm back. I'm just going to do it like this. Perfect. We already did a medial rotation when the patient was in supine lying, but we're going to repeat the medial rotation, but now we're going to do it simultaneously bilateral. And why do we do this? This is very easy now for us to detect, let's say, the range of, to interpret the range of motion. And when you give slight counter pressure or overpressure, then you can check the end field. And a patient with a symptomatic arthrosis, talk about that also a little bit later, this patient, the first movement, which is limited and where the end field is not so elastic anymore, but where the end field became a little bit harder, that's medial rotation. That's the first movement which is, let's say, disturbed in a symptomatic arthrotic patient. And then we have some more resisted tests, the resistant rotations, lateral and medial rotation. In most of the situations, this test is negative. And then we have a resisted flexion in relation to a hamstrings muscle problem and resisted extension in relation to, for instance, a rectus femoris problem. So this is a basic examination. If necessary, you can do some accessory test. And one example of such an accessory test is the combination of flexion and adduction. And let's imagine you provoke quite some pain in the groin by doing this test. Well, your first idea is going to be a beautiful psoas bursitis. More about that also a little bit later on. So to make life easy, we developed some standardized assessment forms where for each joint we have an assessment form with the history, the inspection, the examination, the clinical reasoning. And here you see an example from some test of the hip. You see the different variables. You see which variables are valid for which test. Well, as I told you at the beginning, at the end of this webinar, I'm going to give you the link where you can download this assessment form in PDF, and you just put it on your computer. Okay, 5 reasons. I told you there are more reasons, but tonight I talk about 5 reasons. Okay, the first reason is a symptomatic arthrotic patient. So he has groin pain. Perhaps he has also some radiation of pain, the anterior aspect of the leg. That's also possible. So referred pain in the L2, L3 dermatome. And what you find in the examination, well, you find a capsular pattern and a harder end feel. And the 2 most important movements, which are, let's say, most limited in the capsular pattern, are, as I told you before, the medial rotation. This is the first movement which is disturbed, and also more limitation, and flexion. Later on, perhaps also extension, but medial rotation and is more limited than flexion. This is typical. And when you give some overpressure, so in normal circumstances, you feel the elastic end feel, but now you feel harder. Yeah. And taking an X-ray of that patient, that doesn't make too much sense at the beginning, unless the patient, of course, has constant pain, which is not controllable. But if you just look at the X-ray and you don't look at your functional examination, then you are just treating an X-ray and you're not treating the patient. Because there can be, and you surely know that, there can be a big contrast between what you see on medical imaging and the function of the patient. Actually, in that perspective, medical imaging doesn't interest me too much. The function of the patient, this is more interesting for me. Okay, and what could we do with this patient? Well, from the physiotherapy perspective, if the arthrosis is not too evaluated, so in other words, we don't talk about a big limitation of movement and we don't talk about a bony hard end feel, then you can do capsular stretch techniques. And we're going to stretch in three different directions. We're going to do that in flexion, we're going to do that in extension, and we're also going to do that in medial rotation. Those techniques are not a pleasure trip. No pain, no gain. You really have to go to the end of the movement, try to go further, give some overpressure, stay there for a few seconds, stretch, release the tension, and do it again. And you can do that 15-20 minutes. And it's possible that after the treatment, the patient has a few hours some after pain. That's possible. But if during the treatment the patient doesn't feel anything, then it is not intensive enough. A second option for groin pain is the patient who has an arthrotic hip, but he also has a loose body. And mostly, medical imaging is not going to help you, because if it is a cartilage loose body, of course, you're not going to see that on standard medical imaging. So you're going to hear the loose body in the story. More about that a little bit later. This is quite important. The clinical examination, the test, the clinical image of a loose body can be very variable. Yeah, but in normal circumstances, they have their arthrosis, they have a capsular pattern, and then suddenly some loose body or loose bodies are interfering, and the capsular pattern turns into a non-capsular pattern. That means that other tests become positive, and perhaps now there is more limitation inflection, and the typical harder infield, we don't feel that anymore. Perhaps lateral rotation is painful now, which is not painful in simple arthrosis. So there's a change in clinical image. And what can we do with that? Well, we can have fun with that. We're going to manipulate that. That looks a little bit like a medieval maneuver, but the therapist is going to build in some traction. And under traction, the therapist is going to step off the table. And during what I call this flight phase, the therapist is going to perform some intensive rotations. It looks strange, but it's not painful. It's absolutely not painful. You do that a few times, and you just check. You check the positive test for the examination, or sometimes the patient is saying, yeah, I have some kind of uncertain feeling on going downstairs. Okay, well, let's go to the stairs and let's try it. Okay. If, on the other hand, you see something like this, really severe bony loose bodies, then of course, yeah, you can manipulate. Perhaps you're going to help the patient for a few hours. But of course, that's not the purpose. Yeah, when this is the case, then of course this needs to be removed. This is logical. So I'm interested in the non-visible loose bodies. And when I told you earlier, you hear them. Well, this is the typical story of internal derangement. And very often the diagnosis is missed. They say to the patient, oh yeah, you have arthrosis. Oh, okay, great. But the patient is saying, I have twinges in my groin and sometimes radiation down the legs. Twinge. Sometimes I lose control. I have a feeling of giving way. Yeah. That doesn't belong to arthrosis. Arthrosis doesn't cause those things. But twinges, giving way, exceptionally a feeling of blocking. That's not arthrosis, that's arthrosis and something else. And the something else is the loose body. Yeah, of course, you don't expect that too much in younger people. You expect this more in elderly people. Yeah. Okay. You're still following? If you have questions in the meantime, the chat, I see that already one question came in, but I'm going to come back to that question later on if that is okay for you. Reason number 3 for groin pain, perhaps the patient has a psoas muscle lesion, mostly also sports related. What do you find in your examination? Resisted hip flexion, remember from our basic examination, resisted hip flexion with the hip in 90 degrees flexion. This is the main positive test. But of course, the psoas is a pretty big muscle, but we can't palpate, let's say, the entire volume of this muscle. And if there is a lesion, we are lucky. And why are we lucky? Because mostly the lesion lies in a little corner just medial to the sartorius and under the inguinal ligament. You can see it over here. Yeah, you ask the patient to lie in the Faber position. Yeah, flexion, abduction, external rotation, as you see on this image. Then, well, let me make another drawing. Then you clearly see that the sartorius becomes very visible. Well, where can you find a nice part of psoas? Well, we have the inguinal ligament, and then medial from the sartorius and under the inguinal ligament, just in this corner, we have a part of psoas. Yeah? Okay. As you can see in the previous slide, yeah, the green spot is the spot, let's say the part of psoas we can palpate. Okay, Good. Well, if, of course, the palpation is going to be painful, if there is a psoas lesion. But if I may give you one suggestion, if you palpate with your fingers pretty horizontal. Don't flex your fingers too much to go into the depth, because this is by nature a pretty sensitive area. So I try to avoid a false positive answer. So also compare, of course, left and right. And what can we do with such a muscle lesion? Well, to be honest, a good to-the-point friction massage is an interesting part of treatment. I know that in nowadays, for some people, friction massage is old news, but actually, when you perform it in a correct way and when you perform it on the place where you have to be, then we notice that this could be a very interesting added value. Not always. It depends on the situation. But here, with the psoas, well, could be very interesting. Okay, we already discussed 3 reasons. Yeah? arthrosis, loose body, and a psoas muscle lesion. Well, perhaps all of this that looks pretty easy, or perhaps it doesn't look easy. Well, in reality, it is not so easy. It's logical, mostly, but it's not always that easy. In the meantime, Ahmed asked a question: in psoas lesion, the only test is resisted hip flexion? Yes. And if you do the extra psoas bursitis test, which I showed earlier, of course, this could also be a little bit painful, and the passive flexion, when you squeeze in the psoas, that could also be painful. But the main test is the resisted hip flexion. And another tip I can give you, when you're not sure, repeat the test. Do it several times. Yeah? And compare left and right. And when you do it several times, then probably you're going to see that the more you repeat it, the more uncomfortable this particular test will be. But again, I'm not going to tell you that orthopedic medicine is easy. It is not easy. Yeah, but yeah, you probably know this is my passion. And what is my story? This is a picture which has been taken more than 40 years ago. And who do you see on this picture? Well, whoops, I did something strange again. Yeah, voila, and I'm back. Okay, so who is on this picture? Well, the guy who is lying here, he's my father. And my father was one of the first official Cyriax teachers in Europe. And this picture was taken in the clinic of my father. The guy over here, he's a colleague from Holland, and he did his exam at this moment while Cyriax was watching. And then you see the yellow guy on this picture, the assistant. Well, who is the yellow guy? Believe it or not, but the yellow guy, that's me. Yeah, how old was I? 15 years or something like this, 13, 14, 15, 16 years. So I grew up a little bit in a Cyriax atmosphere. Here you can also see on the picture on the left, Cyriax watching the colleague doing a loose body manipulation of the hip. Yeah, this is another alternative. I showed you one manipulation. This is the second one. And the yellow guy, yeah, giving a hand. And on the picture on the right, you see me in the middle. Do you recognize me? No. Probably not. And on the left side, you see the wife of Cyriax, and together we were doing the dishes. And afterwards, I could enjoy a glass of champagne. So this is the beginning of my story. This is the beginning of my interests in orthopedic medicine. Imagine. And today, of course, with my team, we have courses all over the world. Yeah? And perhaps you were already one of our guests during a live course, or perhaps you already followed some webinars in the past, or you already joined the online course. There are different options. But imagine, and I'm going to disappear from the image right now. Imagine you really would like to go further in orthopedic medicine. You really would like to study what increases your success. And you only study what really helps you, and no artificial hypercomplication, not just really what you need to reach your goals. And you don't have much time. You just have 1 week time. You don't want to lose time. And of course, you don't want to travel too much, so you just would like to travel once. And during this travel, you can combine efficient learning with a wonderful leisure program. Imagine. And imagine that your colleagues on this course, they have the same passion, they have the same motivation, they inspire you. Well, that's possible. Exclusive worldwide. This is the 7 days Mastermind private training in orthopedic medicine, for which only 4 guests are accepted. Maximum 4 guests. And where does this take place? Well, over here in my house, in the International Training Center situated along the Belgian coast. It looks like this in summertime. But then you can ask yourself, how do I get there? Well, you just take the airplane to Brussels airport, and then a driver is waiting for you, your personal driver, who brings you to the hotel. And after enjoying breakfast, of course, then we have to work. And we start with the Mastermind training, as I told you, with maximum 4 guests. We're going to talk about clinical reasoning, about therapy, a real practical training, and of course, the fun is also very important. And let's not forget the lunches. The lunches are also moments where we can empty the heads before we continue with clinical reasoning. And I provide a lot of extensive course materials, more than 500 pages, a lot of films, even more than that. But nowadays, you can view the Mastermind guests, they get all the films through the online learning platform. But even if you don't do the Mastermind, just tonight, surf to orthopaedicmedicine.eu. I have an extra present for you. You can make a free account over there. And through this free account, you have your free discovery course, just for free. And there's also a special app. You can also look at it through the app. Just surf to orthopaedicmedicine.eu and have a look. Okay, just sign in and you have free access to quite some interesting material. And of course, with my Mastermind guest, we have to celebrate the certificate, and we do that in style, of course. Well, if you're inspired by this, have a look at the experience of my previous guests. They are certainly going to share some interesting things with you. So, if that sounds great for you, then I suggest you just go to cyriax.eu/mastermind and download the information, download the brochure. Have a look, okay? 5 reasons. We discussed 3. Reason number 4 could be a psoas bursitis. And this psoas bursa, this is one of the bigger bursae in our body. About 7 centimeters long, 4 centimeters broad. If this bursa is inflamed, it can also swell. And the patient, of course, has groin pain, most likely also radiation at the anterior aspect of the leg. And of course, the palpation is going to be pretty painful. What are you going to find in the examination? This typical bursa test, yeah? Passive flexion, adduction, the combination of the two movements, and then you provoke. Well, I can guarantee you that the patient is going to jump into the air, so to speak. This is going to be pretty painful. Of course, some other tests could be slightly positive. Some passive rotations could be end range, a little bit annoying. That's possible. But the main test is the combination of passive flexion and adduction. Of course, the end feel is also pretty soft, is pretty elastic. Remember this test? Okay. But the patient could also have paresthesia. But I'll tell you something about that in the next slide. So how can you differentiate a psoas bursitis from a psoas muscle lesion? Interesting question. With a psoas muscle lesion, your resisted test is going to be more, let's say, more obviously positive in comparison to the bursitis. Or with a rectus femoris lesion, or with the rectus femoris, your resisted hip flexion is painful, but also your resisted knee extension. Now, what about the difference with arthrosis? Yeah, arthrosis has a capsular pattern with a harder end feel. A psoas bursitis, the clinical image, this is a clear non-capsular pattern, okay? What's the difference with the loose body? Well, you heard it earlier. You hear the loose body, twinges, giving way, blocking. A psoas bursitis is not causing this. To be honest, a psoas bursitis is not the best lesion for a physiotherapist to treat. We can do some things, but not very, very efficient. In my opinion, infiltration is much more efficient. But of course, in most of the countries, physiotherapists are not allowed to do that. In certain countries, of course, in the UK, physiotherapists can do that. In some countries in Asia, but for instance, in my situation over here in Belgium, I can't do that. That's only the privilege of the doctor. Okay, but that's a quite interesting treatment. But the patient not only can have pain, he can also have paresthesia. Imagine this bursa is swelling. Then it's not unthinkable that thanks to this swelling, you can also have compression of some adjacent neurovascular structures. And then the patient can also say, have some tingling feeling. Yeah. So don't be surprised if this would happen. It's perfectly acceptable. Okay? And that brings me to reason number 5, an adductor problem. And there are two popular options when you talk about an adductor problem. And you could have a lesion over here, the insertion, tenoperiosteal, and you could also have a lesion over there in, let's say, at the height of the musculotendinous junction. So we have to do a palpation to differentiate those two. But I think that the tenoperiosteal version is more frequent. Okay, what you find in your examination, of course, your resisted adduction is painful. And they have pain over there. But this is not enough. Let's imagine the patient has a periostitis or has a pubis fracture. Then your resisted test is also going to be painful. So what else do I need? I need also positive palpation. So palpate adductor, the different localizations left and right, and see if there is any difference. Okay? And also here, we have two different friction massage techniques, which could be very useful. Again, friction massage is not the only part of the treatment. Friction massage is, according to our experience, a very interesting part of a treatment process. Of course, we know that with certainly with tendinous lesions, exercise therapy and loading is of course very important, but this is a subject of another webinar, which the recording, you can find it on the online masterclass in the Ultimate Toolbox. But okay, on orthopaedicmedicine.eu. And this is the palpation and the friction technique for the musculotendinous junction. This is, to be honest, quite an intensive technique and quite also intensive for the therapist. So it's very interesting that you, let's say, respect some practical details regarding this technique to make it as comfortable as possible for yourself and for the patient. Yeah. Well, so, quite a lot of information in a short time frame. So we have 5 reasons: arthrosis, loose body, psoas muscle lesion, psoas bursitis, and an adductor lesion. Of course, there are more lesions, but this is going to be for another occasion, of course. But in the meantime, I'm going to have a look at the chat again. Amar is asking how to differentiate gluteus pain and piriformis pain. Oh, well, that's quite simple, to be honest. A piriformis lesion, I honestly think this is very, very, very rare. Yeah, I talk extensively about that in the lumbar spine modules and in the lumbar spine webinars and online masterclasses. That's quite intensive, but we have to keep in mind that somebody with gluteal pain, in the majority of the cases, this is referred pain. In the absolute majority of the cases, this is referred pain from the lumbar spine. So in a minority of the cases, this is a local lesion, okay, a bursitis. But a gluteal muscle lesion, this is super, super, super rare. Yeah, and another thing with piriformis, yeah, the piriformis test could be positive, yeah, but as I mentioned before, could be also false positive, yeah. But if there is compression on certain nerve, then of course the patient can have quite some radiation down the leg. But even then, radiation of pain down the leg in many cases is referred pain from the spine, and more specifically referred pain in relation to a problem with dura mater. But okay, now I go a little bit further. This is subject of the entire lumbar spine online masterclasses. In this free discovery course I was talking about, for which you can make an account, you're also going to find a lesson on lumbar spine. So have a look over there. Yeah. Good. As promised, I still have to give you some presents. Well, if you look at the right side of your screen now, then something is going to appear, and it should appear now. Then you see a banner over there, and you see a link. Click here to get free access. Well, if you click over there, immediately you're going to go to a page on my website where you find the download of the assessment form, the functional examination, the slides of the presentation. But for those of you who watch this webinar in a replay version on another occasion, well, on the slide here, you also see the link where you can find the information. So, and if you would miss it, don't worry. In 1 hour from now, you're going to receive an email from me, and in the email, you're going to find the link to the replay version of this webinar, and also the link to to the free content I just offer you. Well, slowly but surely, we reach the end, and as you know, I always try to have compact webinars not longer than 1 hour, so that it is, let's say, that it is interesting for our brain, that it's not too much. Well, I'm going to ask to you, do you have any further questions for me now in the chat? If you're watching this webinar in replay version, of course, you can also send me some questions through email. Ahmed is asking, what about abdominal hernia? Of course, this is one of the other options for groin pain. But of course, this is absolutely not a lesion for physiotherapists to treat. Of course, passive flexion is going to be is also going to be painful. Perhaps this extra bursa test is also going to be painful. The patient is going to say something is squeezed in, and sometimes, to be honest, it's not always clear. Yeah, I recently had a patient like this, so thank you for this question. I suspected he had a psoas lesion, yeah, but I was not 100% sure. In his story, he said, okay, we started walking more and we do bigger walks and really many kilometers, and so there was an element of potential overuse. But when I do friction massage on the psoas muscle, after 3-4 sessions, I must see a difference. I must see that it gets better. And I didn't see that. And nothing changed. And then we have to ask ourselves, if nothing changes, what is wrong with my treatment? What is wrong with my diagnosis? And then I sent the patient back to the doctor for further examination. And indeed, he had a beginning hernia. But at that moment, that was, for me, not so obvious. So yes, it happens. Elena is asking, does the sacroiliac joint is also cause of groin pain? And what about nerve pain through the groin? Okay, those are 2 questions. Does the sacroiliac joint cause groin pain? Very, very, very exceptional. And the innervation of the sacroiliac joint mostly is S1, S2, a little bit S3. So that means if the patient has a symptomatic sacroiliac problem, then the patient is going to have referred pain in the S1, S2, S3 dermatome, which is posterior, not in the groin. But research has shown that exceptionally there are sacroiliac joints which also have innervation from L2, L3, and then it's possible they have groin pain. But this is super exceptional. I always say to the colleagues now, to you today and in live courses, always look at the package. Always look at the cluster of positive signs, negative signs. And if the patient has a symptomatic sacroiliac problem, there's also a story that goes with it. And you need to have at least 5 positive sacroiliac pain provocation tests. I talk extensively about that in the lumbar spine online masterclass and of course during the live courses. But this is imperative. You need 5 positive sacroiliac pain provocation tests. So don't jump to conclusions too fast. And then the second part of your question, what about nerve pain in the groin? Yeah, there could be a problem with femoral nerve, for instance, that the femoral nerve gets squeezed in for whatever reason. Yes, this is possible. Hassan is asking, are there any differences in clinical picture in hip osteoarthrosis and a femoral acetabular impingement? That's also a nice question. Yeah, there are differences. The hip arthrosis, you just have a capsular pattern with a harder end feel. And that's it. With the impingement, there's also an extra impingement test you can do. I didn't show that now in the presentation, but it's a little bit similar to the bursa test, but not 100% the same. So you're going to have an extra impingement test, which is positive, and the story. So most likely you're also going to have the story of internal derangement, which you don't have with arthrosis. Okay? So that's super. Thank you very much for your questions. Do you have any more questions for me? Ahmed, groin pain is a hot topic and very extensive one. 1 hour is not enough, really. Yes, I agree with you. 1 hour is not enough. But I don't want to I don't want to overheat your brain. But this is also the reason why I developed this online master classes, on orthopaedicmedicine.eu. Just have a look, make the free account. You have the complete course. You have everything. Everything is on there, including a lot of downloads. And the advantage is you can watch it whenever you want, as much as you want. So it's very practical. It's very easy. Or, of course, you come to my Mastermind training over here in Belgium. If you look at the links which you see on screen now, on the Mastermind page, you find all the information about Mastermind. If you're interested in the modular courses we teach worldwide, just click this link. More about the online courses, you find it in the third link. And you can also go to the downloads page, because there I have more presents for you. When you register over there, you get case studies, assessment forms, a number of films, a lot of interesting things which can further inspire you. Okay, so any further questions for the time being? Verende, thank you, Steve. That helps differential diagnosis. Well, it's my pleasure. Thank you very much that you appreciate it. After all, this is my passion, and I think you can see that this is my mission. I like to make things more, let's say, more accessible, more easy for all of us, so that we can help our patients in a more efficient way. Okay, any further questions? Thank you, Trevor, for your kind feedback. Irene, Alexander, thank you, everybody. So in 1 hour from now, you get an email. Check your email. Perhaps it's in the spam. It's possible, with the link to the downloads and the link to the replay version of this webinar. So I wish you all a very nice continuation of the day or the night. Thank you very much for joining me here in this webinar. It was really my pleasure. And soon you're going to get an invitation for my next webinar. But in the meantime, I see that Miglena is asking another question. Is it possible to increase adductor pubic pain by strengthening the abdominal muscles with abdominal presses? Because there are footballers who report such pain after making this kind of exercise. Well, I can be very short. Yes, this is possible. Of course, we can talk a lot about those things, but certainly in the musculoskeletal field, we may not forget also the muscle chain activity. One muscle can, of course, influence the other. And this is something we can't neglect. And your question is a very nice example of that. So thank you very much. Okay, last question. If there are no more last questions, then I thank you all very much. Goodbye, and see you on the next occasion. Thank you. Bye-bye. Ciao.